types of similar viruses in the past, and what we all might, those of us who are people with lived experience, caregivers, as well as professionals, both medical and rehabilitation, what we might want to keep our eyes out for as there is additional population bench and clinical science that's emerging. So how many do we have left, Monica, do you think, to click in?
We're done. We're at our cap.
Great, so terrific. Well, welcome everybody to one of an ongoing series of educational events from the United States Brain Injury Alliance. My name is Jeffrey Lauer, and I serve as the chair of USBIA with a nationwide board of both people with lived experience, caregivers, and professionals from across the spectrum of acute care, post-acute rehab, long-term community-based services, and beyond. Today, we are talking a little bit about, or looking towards a good colleague and friend of mine to talk with us about COVID-19 and its relationship to brain injury. And so I'm just gonna take no more time and just introduce Dr. Hall. Dr. Michael Hall is a staff neuropsychologist at the Veterans Administration Medical Center, receiving his master's and doctorate degrees in clinical psychology from Kent State and an internship at UMass Medical School, State Hospitals, with a 2-year clinical fellowship in neuropsychology at Harvard Medical School. Dr. Hall's clinical interests include neuropsych assessment, psychotherapy, psychological assessment, supervision, teaching, and research. He's a member of the polytrauma and recovery teams, PCT teams, and he's particularly interested in the comorbidities of traumatic brain injury and post-traumatic stress disorder. He spends much of his leisure time with his 4 children, cleaning up after them, breaking up fights, and periodically rushing one of them to the emergency room, as I know. But they usually come out relatively unscathed. But I also want to point out that Dr. Hall is a fierce advocate as well as a researcher clinician. He chairs the Iowa Advisory Council on Brain Injury appointed by our governor, and is well respected both locally, regionally, and nationally. So Mike, thanks so much for joining us, and without further ado, tell us what's going on here.
Sure. So let me start off by just thanking the U.S. Brain Injury Alliance of America for inviting me to talk. It's a scary time with the coronavirus, and I hope this doesn't provide too much scary information, but it's, I think, information that's very relevant. Also like to thank you, Jeff, just for all that you do for people with brain injuries, both acquired and traumatic. Monica Rogers for helping organize this webinar, and Daniel Fenton, who was an intern of mine until just last week and will be starting his fellowship soon. So just to go over some standard disclosures, unfortunately, I don't have any financial relationships with proprietary entities that produce healthcare goods or services, and the opinions that I'm going to talk about today are mine and do not necessarily reflect any agency, government, or state entity. As this pandemic is really in its early infancy, I know that may seem kind of a little bit hard to wrap your head around now that we're 4 or 5 months in, but there are rapidly developing or rapidly emerging research findings that are coming out basically on a day-to-day basis. So I will be touching on the data that some of the key studies that have come out, but it would not surprise me if somebody came out with something tomorrow that was extremely interesting and extremely relevant. So this is an updating process as we're learning more, which is on the positive side. All right. We have several names for COVID, what's now COVID-19. So the novel coronavirus 2019, or the severe acute respiratory symptoms, or SARS-CoV-2, or COVID-19. And I'll be talking about COVID. I'll be using the term COVID-19, but they certainly are all synonymous with each other. So coronavirus 19 has, or the COVID-19, in some respects, fortunately, has some shared properties with other respiratory illnesses that we have seen in the last several decades. That includes SARS, or severe acute respiratory syndrome, and MERS, the Middle East respiratory syndrome. Now, the number of people infected for SARS was around 8,000 and 2,500 for MERS. So far less transmittable, and certainly not as many people contracted it. So, but we do have some valuable data that we obtained from what the effects on the central nervous system are. These numbers are as of a couple of days ago. 14.5 million cases confirmed worldwide, with an estimated 606,000 deaths. In America, 3.8 million, with 142,000 confirmed deaths. Now, just yesterday, there was a story that the estimates of actual contraction may be 10 times lower than what they really are. So these numbers are fluid, and may change as we get better testing and better resources. So, but this does show that this is an incredibly rapid spreading virus. Borders don't stop it. And, certainly this is not just a US problem, but a worldwide problem. So major things that tend to bring attention to individuals with COVID are fever, issues with shortness of breath, cough, and up to respiratory failure. And really more recently, what's emerged is that we're seeing both indirect and direct effects on both both the central and peripheral nervous system. And I'll talk a little bit about the differences between those. And the neurologic complications can be a direct effect of the virus. One example of that is viral encephalopathy or encephalitis, and I'll talk about that, to secondary effects such as lack of oxygen to the brain with use of respirators, and people having just low oxygen saturation levels. So there's a number of different processes that are going on that are having an impact on both the peripheral and central nervous system. So just to take a step back, as a review, the central nervous system is comprised of the brain and the spinal cord. It also has relay neurons, which help with muscular movements. And then the peripheral nervous system is the nervous system outside of the brain and spinal cord that go to muscles, they go to glands, organs. And if you kind of want to think about it in some respects, I don't know if this is the best analogy, but the nervous system could be looked at as an electric grid, where the central nervous system involves the powerhouse and the computer system that operates it, whereby the peripheral nervous system are the cables that connect and then specifically connect into those other parts of the body where nerves impact functioning, particularly muscles. So one of the things that we have found is that that COVID-19 crosses what's called the blood-brain barrier, and we do know that there are other diseases that cross the blood-brain barrier, others don't. So basically, the blood-brain barrier is it's set up so that it's to protect against to protect against any kind of viral pathogens or toxin that may be present in our blood system. Some of the other viruses that we know that cross the blood-brain barrier are HIV, syphilis, West Nile virus, and Lyme's disease, and and SARS and MARS as well. And this raises concerns that there could be more acute symptoms, neurologic symptoms, and also potentially lasting symptoms. So some of these disorders, can wax and wane in symptoms. And at this point, we don't know if somebody who's had neurologic complications may have a relapse later on. And unfortunately, through part of this talk, I like to be definitive, but given that this is such a new issue and an incredible amount of focus is being paid to it, attention being paid to it, that I think we'll learn more as time goes on about the more longer term potential consequences. All right, so this is just a list. It's not entirely encompassing, but I just wanted to kind of highlight some general problems that we're seeing both within the central nervous system and also the peripheral nervous system. And then I'll focus in a minute on some of the more frequent or more concerning processes. So people often present with disorientation, so maybe not tracking where they are, what's going on, some confusion, definitely headaches, delirium, which is a more severe disturbance in mental abilities, such as confusion, reduced awareness, behavioral and emotional changes. Delirium tends to be reversible over time, and oftentimes we will see a delirium in, say, a geriatric patient who might have an infection of, even a urinary tract infection, will have this confusion until we're able to clear the infection. So it's certainly not endemic just to COVID-19. Then we are seeing encephalopathy, which is basically altered mental status. Is another. I'm going to use a lot of words that are similar, but a little bit different. And it's altered mental status, but there may or may not be inflammation of the brain. But when we do imaging, it doesn't show up on the brain. So the next one is encephalitis, which is a little bit more concerning. And there's both viral and toxic encephalitis. And encephalitis is really inflammation of the brain tissue. So that will show up typically on imaging. And I think I have some examples of that coming in. Anoxia, which is a loss of oxygen to the brain. Seizures. Also another big one are strokes. And they're both ischemic and hemorrhagic strokes. And I'll talk about the differences between those. Microhemorrhages, which are just small bleeds in the brain that aren't quite the same as a stroke, but they can certainly over time build up and cause additional, cause vascular issues, or even to the point of vascular dementia. There have been cases of some central nervous system demyelinization. So myelin is a fatty cover that covers the lower part of the brain's axons to increase the signal speed. And if that myelin, if the myelin goes away, then those brain areas are affected. So a major demyelinating disorder in neurology is something called multiple sclerosis. There are we're seeing some rather rare neurologic events, such as acute necrotizing encephalopathy, and I'll do a quick slide on that in a minute. And then loss of consciousness to coma, to death, actually. And then peripheral nervous system, so gustatory impairment, loss of sense of taste, anosmia, which is a loss of smell. And interestingly, smell is registered by what's called a cranial nerve, which is in the peripheral nervous system, is cranial nerve 1, but it then connects back into the olfactory bulbs in the brain. And I'll talk a little bit about how some of that, there's an indication of some transmission of the virus through the nerve, potentially through the nerve tract into the brain structure. We're also seeing nerve pain, and then also Guillain-Barré syndrome, which is where the immune system attacks the peripheral nervous system. So as we go through this, part of this will be in, how the body reacts to it, and then how your immune system may cause some additional problems due to an overactive immune response. All right. Catch up with myself. So the main four processes that I'm going to talk about, which are most common, are viral and toxic encephalitis, strokes, and then issues with reduced or lack of oxygen to the brain, in part due to mechanical respiration and just the disease process in and of itself. All right, so these are just some general points. We currently really don't have data on the prevalence of how many people are experiencing mild, moderate to severe neurologic symptoms, and that's just because we're in this infancy of collecting data and doing research. But clearly, there's going to need to be longitudinal studies that pick up on, what are the long-term status or long-term potential problems that we're going to be dealing with, particularly as a rehabilitation community. And there is, direct indication that the peripheral nervous system is also being affected in a way that could also result in some lasting problems. One of the earlier studies out of China by Mao found that 36% of patients hospitalized exhibited mild to severe neurologic symptoms. So that's a pretty high proportion. And of those with severe disease where they required assistance or a respirator, 45% were found to exhibit severe neurologic symptoms. Now that's a little bit complicated to track when somebody's sedated and on a ventilator, but this controlled for that. Interestingly, neurologic symptoms have been seen in those with and without respiratory complications. So people can present just with a neurologic pattern. One of the ones that have heard most frequently occurring are strokes. So a recent study out of France found that 33% of people that were discharged at the time of the publication, they tested negative for COVID at that time, but they exhibited what was called a dysexecutive syndrome, and that consisted of problems with attention, disorientation, and really poorly controlled movement issues. So there were some movement problems as well. So clearly affecting a lot of different systems within the brain. Anosmia has been talked a lot about in the news, I know, and that's the loss of sense of smell. And a recent study found that there was an association between increased, basically swelling of the olfactory bulb in somebody with anosmia, and over a 28-day period, the symptoms declined, and then imaging showed that the olfactory bulbs were returning back to their normal size, but hadn't quite made it yet. So there's going to be some transitory neurologic or neuroanatomical changes, and probably more lasting ones. There's also been some odd findings that have come about with COVID-19. There are reports that people with oxygen saturation levels, so 95 and above is what we expect from most people. That's how much oxygen is in your blood system. Typically, people who drop to 85 or below percent lose consciousness. And in COVID, there have been people that have been below 70% to even in the 60s. That would make, so that's a little redundant. But with oxygen saturations of 60% that are awake and also able to think to some degree. So not quite sure what to make of that, but it's certainly, I think a very interesting finding. But just adds more confusion to what all is involved in COVID-19's effects. So again, so the first three things I want to focus on are: one, viral encephalitis, and then infectious toxic encephalopathy, and then acute cerebrovascular disease. So viral encephalitis is inflammation or lesions in the brain, and you can see those as I'm not sure if you can see my icon, but it would be the white spots that are coming up on these images. They're basically inflammatory lesions, and associated symptoms often include headaches, fever, vomiting, convulsions, and then consciousness disorders, again from confusion to coma. And really, this type of encephalitis is a direct result of COVID-19. So this is the impact of the virus in and of itself. And so there's viral and there's toxic encephalitis, and one of the ways to differentiate viral encephalitis is that you can check for it essentially do a spinal tap, which is not the most pleasant of procedures, but that will pick up on viral load. And then MRI and CT scans are more likely to show lesions than toxic encephalitis. All right, so with infectious toxic encephalopathy or encephalitis, I'm going to use those terms somewhat comparable, but what we see is hypoxia or oxygen deprivation despite adequate blood flow. And what happens is that the virus permeates and causes damage to lung tissue, essentially what that does then is oxygen is not properly diffused within the blood system. Carbon dioxide isn't taken out at a level that we want. So if untreated and goes over time, it can result in cerebral edema or swelling. Also, it can result in both neurologic, behavioral, and cognitive symptoms. Because there's obstruction to the cerebral blood flow. And the symptoms for this can really vary, and it can be very difficult to differentiate toxic versus viral, and may want to do that spinal tap to be able to differentiate. Toxic encephalitis can be picked up on more blood work, but the two can look very similar. And I won't go too much into how the lung function works because it's below the brain, and then I tend to my knowledge of that is not quite as good. So I'll defer to others to cover those areas. Now, one of the other significant acute manifestations of COVID-19 are cerebrovascular disease. And what we mean by that is stroke. So respiratory infections have been known to be a risk factor for strokes, and COVID-19 has gone the same way. So there's two types of strokes. Well, there's three types of strokes. One is an ischemic stroke or a cerebral occlusion, and that's where a blood clot or a plaque will get kicked up and will block blood flow to the brain. And what that does is it affects surrounding regions of the brain. Then there's hemorrhagic stroke, which is when a blood vessel bursts. There may be a thinning in the wall and blood builds up. And because our skull is our brain is in the skull relationship, there's not a lot of space. So when you start to have a bleed, it can start to create pressure throughout the brain, locally and in broader ways. So it can have a very significant impact on brain functioning. So also when I talk about the cytokine and cytokine storm cascades, this is the overreaction of the immune system to the virus. And this was particularly bad in what's called, quote, the Spanish flu, although it didn't start in Spain, of 1918 to 1919, where the immune response was so severe that some people would pass away within hours of first being, presenting for symptoms just due to this overreactive immune system. Now, this is where with the cytokine storm and the overreactive immune response, that's why I think we're seeing some positive effects with steroids, with remdesivir, which is an antiviral, and then more recently with interferon, which is a medication that we typically use for multiple sclerosis. Some of them bind on to the receptor in the brain and in the body that transmit the COVID virus, which is the COX-2. So there's a number of different. So addressing the immune response is part of the acute treatment. I'm going to skip that and come back to it. So one of the other major concerns about both short-term and long-term cognitive and emotional and neurologic functioning is use of mechanical ventilation. So this isn't new to COVID, but what happens basically is having oxygen levels at the level that you require intubation typically, is a problem. And if it's prolonged, some people are having to be on ventilators for days to weeks to months. And the longer time you're on the ventilator, it's been shown that less oxygen gets to the brain, and people have issues with hypoxia. There's other issues of too much or hyperoxemia, which is too much oxygen and not enough carbon dioxide. The system just isn't regulating well. And so below you can kind of see the scans. The top scans are interestingly, with mechanical ventilator use, it's actually increasing the production of amyloid plaques. Amyloid plaques are really typically, when you think of that, it's in the context of Alzheimer's disease. So we're not quite sure, what that's a part of the factor. And then also certain areas of the brain that are not getting enough oxygen are, have reduced functioning or have necrosis, which is dying of brain cells. All right, let's see. So I'm going to jump back to a less frequent but somewhat concerning several cases that have come out. So there's a disorder called acute necrosizing encephalopathy, which is typically seen rarely in children, very rarely in adults. It has been a rare complication of a viral infection. And involves sort of systemic and multifocal lesions. You have the overreaction of the immune system. We see intracranial hemorrhaging, and I'm going to talk about one of the first cases of COVID that was seen. So it was a woman with COVID who had been confirmed diagnosis with COVID-19. She was 58 years old, and she presented to the emergency department with recurrent episodes of vacant staring, speech wasn't fluid, and they witnessed a tonic-clonic and a grand mal seizure. So she had a history of anemia, but that was treated. Then she was released, and when she came back in, she presented with stomach pain and diarrhea. 10 days before she presented to the hospital, she had developed a persistent cough, sore throat, headaches, and shortness of breath. Within 12 hours after admission to the hospital, she had what's called a Glasgow Coma Scale of 5 out of 15. 13 to 15 is what we call mild traumatic, which is consistent with the concussion. This is consistent with somebody who's really not, was falling in and out of consciousness. And even though she had mild respiratory symptoms, they put her on a ventilator. And the CT scan, I don't know if you can see it so much, but the major images that really kind of show, you can see, sorry, it's H. Yeah, I think it's, so this, the second one in the first row, you'll see a lot of little white dots in there. Those are ischemic changes. So small blood vessels are breaking. And then the latter two slides are on autopsy and just show the deterioration of brain damage. I mean, this is cell brain death at a very extreme level. So, this is not likely to happen too many times, but it was something that stood out, so I just included it. This slide just shows some general MRI images. The first one, you see the arrow. This is in your lungs, and it's just there's a large embolism in the lung that potentially could then break free and then go to the brain and cause a stroke. So the images B through C show an embolic stroke or a brain bleed, and you'll just see it's covering up a huge portion of the of one side of the brain. And then the image D, you'll see some images there showing some holes in the brain as well. So that's not good. The bottom slides really are more focused on cerebral contusion. So smaller microbleeds. But if you see, they're kind of spread out all over the brain. They're the black dots. If we did a different form of imaging, we could look at them and they would come up white, but this is concerning. So and there's a number of other imaging findings that are consistent with this. All right. So in kind of thinking about moving forward, it's growing increasingly clear that it's going to be important to screen for neurologic symptoms related to COVID, even screening people who may not know that they have COVID. So it's a difficult endeavor. We're doing it here at the hospital right now when people are coming in, but it's clear that while we don't know the overall rates of neurologic complications that people may have both in the short and the long term, it's clear that we are going to be dealing with this for years and years to come, whether or not we can get a vaccine and whether or not we get the virus under control. So screening and then treatment when indicated. So fortunately we have experience with all of these presentations. So, we're going to build on our knowledge. I mean, we're just going to, I think what we're going to do in the initial stage is not necessarily related to any kind of pharmacological intervention, but to fall back on what we know about rehabilitation, because this is an acquired brain injury. So also, there's a strong need to provide education and services and supports, acute, and I shouldn't say acute to rehabilitation, because rehabilitation is acute too, but more, starting to think about use of acute and then long-term rehabilitation services. Hopefully we'll get better numbers coming out so we can potentially plan for that on a system level. And then also, continued research efforts looking at the neurologic sequelae or the neurologic consequences, and then really looking at this over time. At this point, we don't quite know if you can get the virus twice, and since it passes into the blood-brain barrier, other viruses that do the same have been found to have waxing and waning issues over time. So it's not inconceivable that somebody who had a certain neurologic process that's related to COVID, that COVID could lie dormant and then reactivate and result in even greater neurologic issues. That's not confirmed, but it wouldn't be too surprising if that was the case. However, prior coronaviruses have not exhibited a progressive neurologic decline as what you'd see with untreated HIV/AIDS. So that's a positive. Let's see. Also, really use of relevant existing networks of resources for those with acquired brain injury. Brain injury, this group, the U.S. Brain BIA would be one. Certainly rehabilitative, people who work in rehabilitation. I think we're really well suited to deal with the functional consequences, and then hopefully we'll get better pharmacological interventions as well. And then ongoing needs assessment. This, COVID has affected, a lot of, basically all aspects of our life. And, being able to track the needs of those people with COVID, who have had COVID and have problems, is going to be critical. And then also for those who have premorbid medical conditions and also premorbid brain injuries that may have a harder time with the disorder and may have worsening of symptoms than those that are that don't have those histories. So this is something that we're gonna, it's going to be important to track. We also there may be difficulty differentiating, kind of what's going on neurologically, particularly in relation to emotional and cognitive factors, because COVID, when neurologic changes, it can have a direct result on mood, personality, and behavior. And then also just, dealing with trauma related to COVID and, increased rates of depression. We're also worried about increased rates of substance abuse or so there could be other, more psychosocial factors that are exacerbating the consequences of this and causing problems with people who don't have the disorder or don't have COVID, but do have problems and just the limitations in their life. All right, so that's my overview. So I think what the plan was is that maybe Jeff and I will take questions, and
we've got a bunch in the pipeline, Mike. So let me just start out. So maybe Monica, can you mute everybody and then unmute Mike and myself, because we're getting some background noise.
Oh, sure.
Thank you. All right.
Maybe
no, you're
sorry,
good.
I'm going to put the slides back up again just in case your questions.
Sure, that'll work. So, Dr. Hall, there's actually, we've got a bunch of questions that are all amazing, one of which I'm going to just spin off from where you just ended. The medical and biological impact of COVID has certainly been taking front and center as it should, for quite a long time. But we're now moving into a phase of this pandemic that nobody in our generation has experienced. And looking back at the 1918 flu, as you mentioned, there's a fair amount of literature that describes that both healthcare professionals as well as the general public experienced significant changes in their mental health at baseline, feelings of helplessness, anxiousness, guilt, anger, confusion, some people abandonment. And so how do I want to say that? You're in that kind of sweet spot where you straddle both the psychological and the medical and the psychiatric. Where do you feel that kind of screening gets added and or that outreach gets added? Or does that need to be teased out specifically from psychiatric, biologically based?
Well, so first of all, the question of how, is something that we need to work on.
Yeah.
For our state, we do brain injury, we do screenings of people who have been in the hospital. Hopefully that's going to happen with medical providers. They'll, those people who have been tested positive. But I think we're going to have to think outside the box and kind of pair that up with education, to let people know, hey, wait a minute, it's not abnormal if you have COVID to have these changes, and also to have, some emotional, and psychological changes that are secondary to the pandemic. We
Yeah.
are seeing issues with isolation.
Yeah.
You know, there's a lot of fear. There's there's mixed messaging coming out. People don't, and people don't necessarily feel like they have a lot of control over what's going to happen to them. So, you know, and it's, you know, in those people with COVID who have had COVID, it may be difficult to differentiate, okay, what's what we call organic or brain change that's
Right.
causing these things versus more of the you know, the consequences of all the changes that we've had in life. And that includes, you know, the unemployment, people not being, you know, financially secure. Those are huge issues. So it adds another layer to it. And, you know, for my work, you know, I'm used to there both being a neurologic manifestation and then a behavioral manifestation. So, but, you know, I think getting out that education component in a concise manner is going to be critical. And how do we do this in a large scale? You know, I think COVID's on you know, on clearly on everybody's radar. But how do we, you know, how I think that needs assessment maybe need to be front loaded as to how do we get people information, you know, and make sure that we have an informed populace and also an informed medical community as well, because, you know, there are providers that are, you know, mostly focusing on the, you know, those hard to breathe, fevers.
Right.
Yeah.
So that's good. So for those of us on the phone, we've got hundreds of us now across the country. Let's cut ourselves some slack. Any of the stuff you're feeling makes a lot of sense.
Absolutely. Yeah. I mean, it's a, you know, I look at a lot of the just the psychosocial changes that all of us are dealing with as a normal consequence of an abnormal situation.
Right.
I mean, that we haven't experienced anything like this in our lifetimes. I mean, we've had certainly other major seminal events in the world, but nothing like this. And, so it, you know, it's covered on the news a lot. There's, you know, again, conflicting information. There's new information coming out all the time, and that can be very overwhelming. Yeah. So cutting yourself a break is really critical. And also, you know, maybe sometimes limiting, you know, how much you're watching news. You know, I don't want an uninformed population, but if you're watching 24-hour, you know, the 24-hour news shows, they have to fill that time, and it can, you know, can become overwhelming.
It can be. So then we're going to go down a rabbit hole real quick that's a little bit more specific. Number of folks are looking and working in the area of athletic training and sports-related concussions, working with kids. And in some areas of the country, athletics are going to take place in some form this fall, and there's still the potential for concussion. But if you add the layer on that, that COVID's out there with the subsequent potential neurological impact, should people be thinking about a lower threshold for imaging? Should kids with concussion be held out longer so that they're not exposed to COVID on top of their recovery from concussion? You know, this is another layer of nuance that wasn't even being thought about last year at this time.
Absolutely.
Do you have any thoughts about that?
Well, I mean, there's a couple avenues with this, with you know, kids going back to playing sports.
Right.
There's the increased risk of concussion just by the nature of the sport they're playing. Right. So that we're used to that. Now, as I mentioned, that there are people who are going to have neurologic symptoms that don't have the more cardinal, most paid attention to symptoms of fever and shortness of breath. So, and COVID can affect movement as well, which can potentially increase the likelihood of concussion. So, you know, I worry about, you know, first of all, and can we play sports safely? You know, we're sweating, we're breathing you know, you know, usually out of breath at certain times. So, you know, I would probably err on the side of caution with respect to, you know, if somebody does start to exhibit any kind of changes or has a hit to the head, to pay even more attention to that, because there might be these underlying factors. Now, whether or not we should be returning to sports, that's at a pay grade higher level in mind, but it worries me. And you know, because people have talked about kids not having the same response to the virus. Well, you know, that may be true, but you know, we live in a larger context, and kids are coming home, and you know, the spreading of the, you know, that increases the vector spreading. And so those are very contentious issues, but as a provider, I want to see as few people develop COVID as I can. And, the hope is that, we can follow the CDC guidelines, social distance, you wear masks, and then hopefully, a vaccine will come out. And one of the, I think it's the Cambridge group, recently just released data that they have a vaccine that hits two aspects of the immune system and looks like it's, we don't know how long it might last, but it's looking promising. So, I think a lot of things potentially will be on hold until we have a vaccine that's safe and effective.
So then I'm going to take us back in time for a second, and this is a question that I have and I bring to the table. The pandemic, the only other pandemic that I'm aware of that we've had that in history is the flu pandemic of 1918. Coincidental to that, there was another pandemic that's well documented, which was a pandemic of encephalitis lethargica, also known as Van Economo's encephalitis. And it was a mysterious epidemic that swept the world from 1917 to 1928, a neurological epidemic that paralleled the 1918 Spanish flu. And if you match up flu with coronavirus, there are not all, but many similar symptoms.
True.
With at the end of the day, epidemiologists still argue about whether encephalitis lethargica was caused by or just coincidental with the Spanish flu. And so the debate's still there, but it was observed across many countries. England, they called it the English sweats. Italy had a couple different names, Nona, Malmazuco, Germany, Sweden. This was, it was a widespread piece. What I see from your slides, if I'm not mistaken, is not the assurance of, but a distinct possibility that there will be or could be a subsequent kind of illness that's caused both by the virus and how it operates on the body, but then also, in addition, the mechanical ventilation that you were talking about, the treatment-related piece, where people may well have long-term neurological symptoms. And that's really, for me, I hadn't thought about that until I was preparing to talk to you today. That's kind of a pretty big deal.
Right, and within that, within the debate about those two illnesses was this a potential genetic modification or a genetic change of the virus? So we've I think it's been well documented that there has been a change where the virulence has gone up. No, what was it? The virulence had gone up, but the severity hadn't.
Got it.
And this is within COVID-19 now. So this, there is a potential that the virus may change. And there's certainly, given that it crosses the blood-brain barrier, we don't know, is COVID-19 going to be stored in the brain and then lead to, either, the known issues that we're having now or something novel?
Like herpes or chickenpox.
Some kind of progressive neurologic change. Oh, wow. Similar to HIV. Early in my work, I looked at volumetric changes in the brain for people who had AIDS prior to the medications we have now, and you just see the ventricles explode over relatively short periods of time. And I'm not trying to be alarmist here, but these are things that we don't know. And given that this is novel coronavirus, we can look at other coronaviruses and say, okay, we saw toxic viral encephalitis, the other issues, but this is new. So yeah, that is a potential, and that's the real, I think the real impetus for the need for longitudinal studies, where we track this over time, and extensive ones too, where we're looking at neuroimaging, we're looking at biomarkers, we're looking at clinical presentation. Right. So I see a lot of research that's going to need to be done to look into that. And again, I don't want to worry people more, but it's certainly, that's certainly something that could happen.
Okay, if you weren't anxious before the webinar, you can be now, everybody.
And here's the thing: is I am talking. I probably shouldn't have included the one, maybe the very rare one about death, but because I don't want to worry people that that's
Sure.
what they're going to come down with. But it just shows how severe this can be, and how much of a very quick degradation of the brain can happen. Yeah. And then also, with the strokes, we've known that there's certain risk factors such as age, diabetes, hypertension, and obesity. so there's these premorbid, complications that put people at risk and put people at risk for specific issues. So if you have diabetes or hypertension, the risk of a vascular event or a stroke increase. So I think, we'll get a better understanding over time as well about what comorbidities, are the most significant, and what do we do about that?
Got it. There's been a couple of questions, Dr. Hall, which I think I know your feeling on this, and I'm going to just take a USBIA stance about the benefit of physical distancing / social distancing and or wearing masks. And yeah. I think we'll come back. I'm going to take this one on behalf of USBIA. We default to the WHO, World Health Organization, despite the fact that the United States no longer abides by WHO. I think we may be back eventually. But there's a concept called the precautionary principle, where when the risk of an action or inaction is significantly high and the cost or the effort to take that action is significantly low, such as physical distancing and or mask wearing, and it's not without cost, don't get me wrong. It violates people's rights, it violates people's sense of freedom, it violates our basic need for human interaction. I get all that. But given what we're looking at right now, and the second wave that's hitting now in a different way, which matches very much the great pandemic of 1918, in which there were 4 distinct waves of that flu virus that functionally kicked the world's butt. We definitely still recommend that people, if you've written the question here, the answer is yes. We do recommend that you wear face coverings, face shields, masks, and that you physically distance. Let me go to a question from Russ Spearman. Russ is asking a question about kind of the broader neuropsychological dearth that we have out in the world. There are many states that have expanded their Medicaid programs for people with no health insurance. And many states now are screening for a lifetime history of TBI, much like we are here, Mike. States are struggling with helping those people, though, get an actual diagnosis. Waiting lists can be a year long for testing. Do you have any thoughts or suggestions about how a state agency can increase access to neuropsychologists and or others to diagnose for TBI? Is there a magic or a trick to getting people access to diagnosis?
Unfortunately, no. Okay. But here's the thing. But let me take a caveat to that. Is there are other professionals that do cognitive screenings that could be very helpful. There's the MOCA, there's the mini mental status exam that are usually based on a 30-point scale, and they cover various different cognitive functions. They're not very specific. I mean, they're it's very easy to come up with a 30 out of 30 on most of those measures. But I think neurology is in a very good position to be able to do more. I know that I've seen since COVID come out that primary care is doing these brief cognitive assessments, and so are psychiatry. I think it's going to have we're going to have to expand out comfort level, and I've thought about doing some training with physicians that are interested in that, because there just aren't enough neuropsychologists out there as it is, with the waiting lists you describe. Because if you have to wait 6 months, what's changed then? And what's going on? I would hate for rehabilitation to be held up during that process. Also, speech pathology, potentially occupational therapy, are other mechanisms to assess cognitive functioning, and then also just daily functioning, which is often very highly tied. Now, will everybody that have COVID need a full neuropsychological exam? No, I don't think so. But certainly there are those that we're going to want to, have a quantification of the problems, and then also provide a picture of the problem so we can help, guide the rehabilitation process. Because I fully expect that, all the people that are involved in rehabilitative services now will be involved, with COVID patients, doing similar things that they do now. So cognitive rehabilitation, physical therapy to work on movement, gait, balance. Right. Occupational therapy to increase functioning, with daily functioning. So, but that's just, as we're low on providers just for acquired and traumatic brain injury now. So how much are we going to tax this system that's already, is already, has a high degree of waiting list? That's a large systemic issue that I hope we do deal with, because we want to get people treated quickly, assessed and treated quickly, as quickly as possible.
Thank you. There are two other categories that I'm going to touch on. We might get a third question in. There have been a number of questions about pre-existing conditions. Are there people with pre-existing conditions, specifically kinds of brain injury, that make them more prone to COVID manifesting at a higher intensity or impact to the brain? Specifically, one, does having a brain injury put me or my loved one at higher risk of COVID? And then two, if so or if not, does it put them at higher risk of having a bad outcome from COVID, even if it's not a higher incidence of getting the illness?
Okay, yeah, and those are great questions. So at this point, we don't. So the major research that I've seen, the major pre-existing conditions that we're focused on are diabetes, which can affect your immune system, hypertension, which can affect the vascular system and predispose somebody to potentially developing a stroke. Obesity, it's tied in with metabolic syndrome.
Right.
Now, what I have not seen are specific studies that have looked at are those people who have had a brain injury with residuals, with residual issues from that brain injury.
Sure.
Are there immune response? Is there an immune problem where they're more likely to develop COVID? That I don't know.
Okay.
Now, if somebody has a brain disorder and they develop neurologic symptoms secondary to COVID,
Sure.
or secondary to some, secondary third process, whatever, my expectation would be that there is the potential for a greater impact of the effects of COVID. We see that with people with traumatic brain injuries that have a stroke. There tends to be more of a, I'd say, a cumulative or effect. So for those people who have had brain injuries with residual issues, I would consider, or neurologic issues in general, like prior strokes or other cerebrovascular issues, to be extremely cautious about trying to follow those CDC guidelines, which are the social distancing, the mask. I mean, I wear a mask and a face shield if I walk out of my office, and we're not seeing patients in person right now. So, I know it's not the best thing to do. It's not a great fashion sense, but the studies are coming out showing that it markedly reduces contraction, and about 80 to 85% of people seem like they're going to have either no symptoms or mild symptoms. But you never know. And there's no group that we've seen so far, whether it's infants to adolescents, to children to adolescents, to, young adults, old adults, that are immune. So you never know. I mean, the chances are that if you're older and have more conditions, that you're going to have a worse you're more likely to get it and then have worse outcomes. But we're seeing this within younger populations. I mean, 20-year-olds that are physically healthy that are coming in with strokes, and that's a direct result of COVID-19. But I don't want to have people, here's the other thing with brain injury is that, people who have prior histories of acquired or traumatic brain injuries often, have limited social resources. They're limited in maybe being able to get out in general. And, I worry about how they're doing. And we've had these conversations, Jeff, and I'm just really proud of what the Brain Injury Alliance of Iowa is doing as far as reaching out and doing a needs assessment that's broader than medical. It's, are you getting food? So I certainly think that, it makes sense to kind of replicate what you're doing in Iowa within the Brain Injury Alliance and Association, is to reach out to people that you've worked with before and check in. Again, some people may have COVID and not realize it. Others, maybe just very worried about it, and information and, just providing, helping inform them can reduce a lot of the anxiety that goes along with it. But yes, I do worry that those with histories of neurologic issues are going to be at greater risk for neurologic complications should they get it. Now, the immune issue and whether or not it's more likely to contract it, that I'm not quite sure about. And I have not seen data on that.
So, I think that just boils down to, if you've had I'm a family member and someone who's had brain injury, it just makes sense to be at least as vigilant as the most reasonably vigilant person. Does it mean you have to live in a bubble? No, but be aware that there are risks, and there's probably a higher risk if you've already had a brain injury, an acquired brain injury. And special thanks to Laura for pointing out on the chat feature that I often default and say TBI, when in fact that's not what I mean. We mean to say ABI. We've spent too many years based on federal definitions saying TBI, and it's a default. The next generation of folks, I promise you, Laura, won't start out by saying TBI. They'll start out by saying ABI, because stroke and all the rest of the conditions that are not traumatic are absolutely in this wheelhouse that we're talking about.
Yeah, and what I wonder about is, are there going to be differences in the manifestations for those with traumatic brain injuries versus those with acquired? You know, it's particularly in the area of stroke. That's a worry. Yeah.
Well, this is really helpful. The only other question that came in here, Mike, that is from a speech pathologist who asked, do you have any early thoughts about what speech therapists, speech pathologists should be looking at if they're having patients come in following COVID and who might be struggling with some kind of neurological changes? Are there tricks or places or tests or thoughts that you have on how to guide?
Well, that's a great question. So which, you know, there's going to be a variability in presentation of, let's just stick with cognitive problems. There's indications that there's some frontotemporal findings, and with one process, if you have a stroke, it's going to be more localized. If you have anoxia, it could potentially be more generalized. So really, you know, doing the assessment component is an important one. And for speech pathology, you know, I know neuropsychology and speech pathology sometimes fight over who should do testing, but I think certainly, you know, speech pathology has a great wealth of experience with cognition, and assessing the major areas of functioning are going to be important. Also, you know, if hopefully there'll be information if the person's had a cerebrovascular, asking about where the stroke happened. But yeah, I think that, doing the assessment is going to be the first step, and then, you know, using the modalities that we have now to address those specific findings. Our hope is you know, that's going to be the best, the best process, because at this point, with a number of the neurologic symptoms that people are experiencing, should get better over time. Not all of them, but, you know, with stroke, we see typically we see a natural recovery, and after traumatic brain injury as well. So the hope is that we'll see the same here, but also focusing particularly on how the person's functioning. You know, can they pay their bills? Can they, you know, are they leaving stuff on the stove? Are they getting lost driving? So not just looking at maybe cognitive numbers, but also looking at more what we call ecologically valid symptoms. You know, are people struggling in areas of their life, and to address those, as quickly as possible.
Helpful, really helpful. I mean, it comes down to that practicality, Mike, which is, at the end of the day, that's what keeps people going.
Yeah, at this point, there's nothing that I've seen that's acutely new to COVID-19 as far as neurologic processes that we haven't seen before. So that's and again, it's early, but we do have then some experience, varying degrees of experience working with populations with those deficits. So, my hope is that, we have the people in the, that can do this work. It's just how much are we going to tax that system, as you talked about before? And also importantly, how are we going to pay for it for people who don't have coverage, and people who may have lost their jobs and lost their health insurance. So,
we're advocating for it. We're advocating for it. And then the dilemma in being successful at advocating for this is, sadly, and as is happening right now, COVID has swept up a fair amount of the opioid epidemic money, and so it's that issue of, and
it's at a time where we worry about increased substance use.
Absolutely.
Coping with it. So
we've got a lot of things on the plate, but we'll do our best to make those policy decisions. That's above my pay grade, but we'll jump up and down for brain injury.
Well, but I do want to jump back to just,
Yeah.
I really appreciate what the Brain Injury Alliance of Iowa has done, which is reaching out to people that you've served before.
Mm.
I think that's a phenomenal idea. And I'm so glad you've done that. Because, first of all, it just reconnects, and then also allows that opportunity for somebody to talk about this who may not be able to talk to a professional, and then also to look at, the broader needs. There's acquired and traumatic brain injury, can affect somebody's ability to even go to the grocery store.
Yes.
And then the concern about contracting COVID adds additional things. So, I think that the more states or entities in the states that can reach out to
Right.
people who are, you've worked with before, I think that's a best practice as far as I don't have data yet, but I just really appreciate you guys doing that. And I hope others do the same.
They are. We're not the only ones.
Good.
The top of the hour has come, and I very much want to thank you, Dr. Hall. Your efforts here to try to pull this together over the last couple of months. There's a white paper that Dr. Hall has that he's polishing a second draft on that he'll share, as well as the slides. We'll post those. We'll send emails to all of you who are registered, letting you know when they're on the usbia.org website. Dr. Hall is not international. I've seen you nationally, and I know you've been international. Speaker on the topic of brain injury. He's got an amazing portfolio. He has a team of partners who speak about both the lived experience of brain injury. Who's your colleague who you've done that show with?
Dr. Kerstetter, who actually his book's right here. He survived a stroke, and it was a combat physician. It's called Crossings, a doctor's story soldier, and I would recommend it. It covers stroke and rehabilitation from a doctor's, from a physician's perspective,
right.
which is I think really interesting. Now he does say nice things about me, but that's not why I'm recommending it.
And although you said nice things about me, I know that you'll say other things out later. So on behalf of the United States Brain Injury Alliance, everybody, thank you for joining us today. I think we will bring back Dr. Hall, if he's willing, in 3 to 6 months to try to circle back on this. This topic has implications for people as they're trying to think about return to school right now. I've already got a couple of posts here saying this could be a game changer in my school district. If our superintendent knew that kids were at risk of neurological consequences, there may be different thoughts about that.
And potentially 1 in 4 teachers as well. I mean, there's no easy decisions with this, but yeah. So
really great information.
Getting the information out is the critical part. So yeah, I'd be more than happy to come back again and provide an update. And I can assure people that I just finished with a set of grant reviews. This is being taken very seriously, and the research that's been done so far is pretty phenomenal and multi-collaboratory across the world. So I've never seen something as rapidly investigated and thoroughly investigated as COVID-19 in my career.
Well, that's encouraging because there's so much we don't know, but there's a lot that the world's putting to bear on getting to know. So on behalf of the United States Brain Injury Alliance, we're going to bid everybody adieu. This webinar will be posted in the next few days. And if you have any questions or concerns, you can email us at info@usbia.org or go to the website. There's a contact spot there as well. And if you have additional questions, I know there are a couple people, you can email me at glauer. It's in the chat box, glauer@usbia.org, and we'll circle back to you and try to get you some answers. So thank you, Monica, for your support for this, and we'll call it a day.
All right. And thank you for everybody for participating.
Thank you, everybody, very much. Thank you, Dr. Hall.
Okay.